Thumbs up then I'll start. Thumbs up दे देना मुझे. Okay. Okay, मैं शुरू करूँगा. Okay. Okay. So good evening, guys. If I'm visible and audible, please give me a thumbs up. Students who are around. Waiting for messages from your end. Yes. So good evening, Dr. Khan, Dr. A for Andy. Good to see all of you, all the people from yesterday. Hopefully yesterday there was some good revision that you people had. Let's go ahead, okay, without wasting any more time. Or we'll wait. Okay, Dr. Med Psycho is also there. Good. As I said, I like the interactive sessions. So let me just keep the things in front of me so that I can read your messages properly. Just give me a second. Okay, so good. Right. So Dr. Khan, Dr. A for Andy, Dr. Med Psycho. Yes. Let's start. Okay. Yesterday we did discuss a lot of controversial questions, huh? Hopefully today also we will have. Okay. The point is, it's not about controversial questions. It's all about the last 5 or 6 papers. As I said, we are discussing all the previous year's questions. So these are the last 5-6 papers that have been asked continuously, and most of the questions I've covered. I don't think I've tried to miss out on anything. There are of course few extra questions also, but at the end of the day, what is happening is we will be having finished our revision of the previous year's questions, right? And if you have realized from yesterday's discussion, again I want to point out the fact, as I told you yesterday also, remember oxygen delivery devices, please go through this again. Please go through airway, please go through CPR. Airway means intubation. Huh? Yesterday there was hardly any question based on intubation apart from endotracheal tubes, but today we have questions based on intubation and LMA also. So these are important ones. CPR and monitors. So of course this includes a lot of anesthesia. I'm not denying that, but I'm just saying that before going to exams, please read through these 4 topics. Okay, these 4 topics are very, very important. Of course, pharmacology of drugs is also there, but please don't miss this, right? Yesterday, when we had started, this is what we had finished out, right? This is what we had finished out, right? ACLS, BLS, correct. So we had discussed this point. Today, going forward. Acha, one more point. Yesterday, I shared the PDF on the Telegram group. Hopefully, people have got it. So today also, I'll be sharing the PDF once we have done with the class. And please remind me that I need to save. Okay. Now, this is more of a medicine question, but yes, we've covered it as a part of anesthesia and critical care also. So I'd like to see your answers and then we'll discuss. A 23-year-old female patient was having fever from last 1 week. On the monitor attached, the following rhythm was seen. This is the rhythm which you see. What is the diagnosis? Is it supraventricular tachycardia? Is it ventricular tachyarrhythmia? Is it atrial flutter or atrial fibrillation? Okay, these are the 4 options. So Dr. Med Psycho has given the answer. Dr. A for Andy. Answer दे दो. Answer कौन सा होगा तुम्हारा? What is your answer on yours, according to you? Dr. Med Psycho has given one answer. Huh? I'm waiting for other people. Anyone else? So, as Dr. Med Psycho has said correctly, it's atrial fibrillation. There are few points. I know medicine people have discussed it in detail, and you people must have already seen it and known. But I would also just like to point out few things. Whenever you see a ECG always remember the first few things that you should be seeing is one of the things is the rate, and second thing is the rhythm, right? With the rate and rhythm. So here, if you have to count the rates, a lot of people say, you take about these 4-5 squares, count the number of things between that. Anyways, all that is very simple. Forget the rate now. But here you will see that basically our ECG is P, QRS, and sort of T. This is exactly what is a ECG. P wave, you get a QRS complex, and then there is a sort of T. P is for the atria contraction, QRS ventricle contraction, T wave ventricle relaxation. Okay. So basically this is telling about the atria, this tells you about the sort of ventricle. This is the point. Now you have to see whether this is coming regularly or not. If you will see, you get one QRS here, you are getting then here, but then some comes early, some comes late, some comes early, some comes late. It's coming so late. That means there is some arrhythmia. So some typo is there. But is it a ventricular arrhythmia or not? That is what we need to see. Atrial flutter or atrial fibrillation. So supraventricular tachycardia is kind of ruled out from here with kind of arrhythmia which is there. Right. Look at the other morphology before we can go forward and say things on that. Next thing is that, as I said, you need to identify a P wave. You need to identify QRS followed by the T. So P wave, if I see, there is some P wave here. But after that, do you see P, 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 P? I don't know whether it's P. I don't know. This is P, this is P, this is P. No idea. So the point is, in this ECG that you see, a P wave is not seen. A normal ECG is like this, right? P wave, QRS and T. This is a normal thing. But this is exactly what you find absolutely irregular, right? You don't know what is happening. But yes, if you will find the QRS complex, it is narrow, it is normal. So therefore the P wave is not seen, or it's not, morphology is not very clear. If you see the QRS, you will find the QRS is coming, but it is irregular, right? RR interval, as Dr. MedPsycho puts correctly, it is irregular, which means every P wave is maybe not followed by a QRS, or you can't identify the P wave. So therefore the problem is lying in the atria, and therefore according to me, yes, so supraventricular tachycardia and ventricular tachyarrhythmia is out. Okay, so it's basically related to the atria. Now the two options in front of you are atrial flutter and atrial fibrillation. So the difference between them is, when you will find atrial flutter, it's more like, QRS followed by a sawtooth pattern. There's a sawtooth pattern that you see. So atrial flutter, you will find this to be more like a sawtooth pattern. Sawtooth is this way. Sawtooth pattern. Okay, sawtooth pattern will be like this. Okay, in between the P wave will be like this. That's atrial flutter. So as Dr. MedPsycho has correctly put in, here the answer is atrial fibrillation, and this is the correct answer for this. Okay, so we'll not go into a lot of details of it, but remember, such types of questions regarding ECG have always been asked, and here the correct answer becomes atrial fibrillation. Let's go fast to the next question. Okay, now this again is a more question related to ICU, right? Sort of ICU or critical care or anesthesia, as you can think. So please mark the answers and then we'll discuss it out. So there was a development of a high airway pressure, increased resistance. Dr. MedPsycho says regular RR interval 2 in atrial flutter. Dr. MedPsycho, correct. But more important, what happens is that sawtooth pattern becomes very characteristic. That sawtooth. As soon as you see atrial flutter, you will understand after the QRS, which is regular. More than that, you find this it's a very typical thing. So like if someone says, what is your take home message? The take home message for atrial flutter and not fibrillation for atrial flutter is going to be just the sawtooth pattern. Sawtooth pattern is that atrial flutter, right? Of course, as Dr. MedPsycho has correctly mentioned, all the things are correct regarding this. Okay, absolutely correct. But I'm just trying to say that one thing which is take home message from which you can remember. Okay. Anyways, medicine people have taught you much better, and I think most of you would be knowing even better than me. But since this question was there, I included it. That's the only point. Now, the next question, there was sudden development of high airway pressure, increased resistance, and sudden desaturation while trying to secure a central venous catheter. What is the most probable diagnosis? So, Dr. Khan says the answer B. Dr. MedPsycho says the answer B. Right? Arterial puncture, pneumothorax, collapsed lung, air embolism. So, most of you, two of you have given me the correct answer. pneumothorax. Okay, so when you are finding, you're inserting a central venous catheter. What is a central venous catheter, guys? So central venous catheter is this. Okay, something which is called as the central line. Okay, this is what is called as the central line. So if you're inserting a central line, a common point becomes, what are the places where do you insert? What are the sites of insertion of a central line? So internal jugular vein is the most common, right, Dr. Andy? You also said correctly. So sites are the internal jugular, the subclavian vein. Okay, then you have the femoral vein, and in the hand you can have the basilic or the cephalic vein, right? So these are the, remember, it's always a vein, it's not an artery. So site, remember, it's a major vein where it is inserted, it is not an artery. All right, so if you will look at this, so whether you are inserting a subclavian, all right, if it's a subclavian, right, so if you insert it from here, this is subclavian central line. If you insert from here, this is internal jugular central line. If you insert it from the hand, it may be basilic or cephalic central line from here, and here is femoral central line. So these are the central line lying in the major vein of the body. What is the central line doing? Central line basically tells you the fluid status of the patient. If I have to say fluid status, what is the meaning of that? Basically the central venous pressure, which normally is 8 to 10 centimeter of water. This is the information that you get. Apart from that, it is in the vein, so you can give any medicine, you can give any drug. So basically it becomes a line from where you can give total parenteral nutrition, you can give medicines from there, you can give chemotherapy from there. Okay, this can also be used for pacemaker wire can be inserted from there, right? Dialysis can be done from the femoral central line. So all these becomes various uses. Apart from that, all the major surgery, right, ICU patients, all these people will have a central line where there is a major fluid shift happening. So these become the uses of it. So central line is always inserted if you need to assess the fluid status of the patient, from where you get to know the CVP of the patient. This is the place from where you can give the medicines, especially the cardiac medicines, the vasoactive drugs, all these medicines. It's a good place to give that. Total parenteral nutrition, chemotherapy can go from there, pacemaker, dialysis, right? These are the non-anesthesia. No, apart from fluid status, others are non-anesthesia uses. In anesthesia, for any major surgery, any critically ill patient or ICU patient, you might need to insert it. So major surgery means transplant, cardiac, neuro, major plastic surgery. All those surgeries would be having a central line inserted in the patient. So wherever there is a major fluid shift that you are expecting, right? So these are the uses of a central line. I've already discussed the site. Next question that comes, what is the position? So can you see, this is the exact position of the central line. The tip of the central line is supposed to lie at the junction of the superior vena cava and the right atrium. Okay, it's at the junction of the superior vena cava and the right atrium, which is confirmed from the X-ray, again asked in the exam. Can you see this? Okay, so this is what is said as the X-ray picture. So tip of the central line lies there. Now the most common sites to insert the central line, basically guys, is your internal jugular vein. This is the most common, and the second most common is your subclavian, right? Now imagine when you're inserting a central line, it's in a major vein, and you always know there is a vein, artery and nerve. So if you're injecting in the vein, immediately you can cause damage to the artery over there, an arterial puncture. Plus it's going in the heart, you can cause cardiac rupture, it can cause arrhythmia. So these become the complications. All right, so very common complications would be arterial puncture. In fact, this becomes the most common complication, arterial puncture, right? Because artery lies just next to it. Apart from that, you can have damage to the CVS, cardiac system, right? Heart, basically damage to the heart, and there can be arrhythmias, right? So that arterial puncture and bleeding will all lead to hematoma, Dr. MedPsycho, correct? So let me put it this way, as Dr. MedPsycho has said, that arterial puncture causes bleeding and bleeding can lead to hematoma. But guys, more important, another important point is that when you're inserting a central line, that too in an area which is close to the apex of the heart here, apex of the heart is here, especially when you're inserting the subclavian and you're inserting the internal jugular, you can damage this area of the, lungs, the apex of the lung, apex of the heart, I said, I'm sorry for that. This is for the lungs. So the apex of the lung is coming over here. So in that case, you can cause pneumothorax, which becomes a many complication that you have to be worried about. So a similar question was asked, especially in INICET. So therefore, remember guys, the most common is arterial puncture, and of course there is pneumothorax. These are the major complications. But if you insert on the left side, guys, remember there is the lymphothoracic duct passing here close by, and this can cause chylothorax. This was a INICET question related to central line, huh? Right? It can cause arrhythmia too, right? I've written that, Dr. Med Psycho. So remember, pneumothorax and chylothorax are also important, and this chylothorax is especially common on your left side more than the right side. Okay, so remember, this is again a complication. So now when we are discussing all the complications that can take place, is air embolism possible? Yes, during the insertion, air embolism is possible. In fact, air embolism is also possible, and venous embolism is also possible. Right? Sorry, venous air embolism is also possible. So this is there, air embolism, arterial puncture, yes, it can happen. Pneumothorax, yes, it can happen, and of course, it can lead to the collapsed lung. But if you are finding the airway pressure is increasing, the resistance is increasing, and saturation is decreasing, it's not because of arterial puncture, it's not because of the embolism. Yes, embolism can also cause certain desaturation, I'm not denying that, but embolism is not going to cause so much increase in the airway pressure and resistance which is there. It is going to be seen more with pneumothorax, right? And one more point is, no doubt, central line is, during central line you can have a problem of embolism, but many times it's also used for the treatment of embolism, right? So remember, these are the various side effects that you can see: infection, hematoma, bleeding, arterial puncture, hemothorax, pneumothorax, chylothorax. Okay, chylothorax. All right, damage to the heart, as I said, cardiac arrhythmias, and venous embolism, air embolism, all can be seen as side effects. But here, according to me, the most common thing is pneumothorax, apart from arterial puncture. If arterial puncture is not there, if you're not getting signs of arterial puncture, the next would be pneumothorax. And on the left hand side, this is especially common on the right. On the left hand side, especially, it is the chylothorax. This was a INICET question, chylothorax. Thumbs up, everyone. Clear? So we discussed central line also. Okay. Next question. If there are any doubts, ask me. No doubts. So we go to the next question. Spinal cord in adult terminates at what level of the vertebrae? Okay. Upper end of L1, upper end of L3, lower end of L1, lower end of L3. Oh, Dr. Tech with Alex is also there. Good. Thumbs up from both Dr. Med Psycho and Dr. Tech with Alex. Dr. Khan gives an answer. Dr. Med Psycho has given an answer. Anyone else? Any other answer? Dr. Harsh gives an answer. Dr. A for Andy gives an answer. Dr. Tech with Alex. सबने A आंसर दिया है, क्यों? According to me, the correct answer is C. C. We are discussing adult. Okay. When you speak of adult, guys, remember, the way to remember was the lower border of L1 and the upper border of L2. This is where the spinal cord ends in an adult. Yes, Dr. Khan, correct. Lower border of L1, upper border of L2. Okay, so you remember it as L1, U2. Okay. 1 का lower border, 2 का upper border. L1, U2. Yes, correct. And in child, it ends at L3. Absolutely correct. Basically, they say at the lower border of L3 in a child. And that is why you find that when you're giving spinal anesthesia in a child, it's not contraindicated. Remember, spinal anesthesia in a child is not contraindicated. But because the spinal cord is going till the lower border of L3, we normally tend to avoid spinal in a child. Okay, we normally avoid, it's not contraindicated. In adult, however, it is up. So therefore, if you look at the patient, so lower border of L1, Dr. Med Psycho, I told you it's better to get confused here and have your concepts clear. So remember it as L1 U2. Okay, L1 U2. Lower border of L1, upper border of L2. I mean, this is one way that I remembered. You can remember from whatever way you want. Everyone has a different way of remembering. Okay, so L1 U2 is what I had remembered. If I have to change it now, actually how I remembered, I'll tell you like this. आप समझ में आया? That is the way to remember. I love you too. Okay. अब easy हो गया everyone. All of you. Yeah, I'll tell you this also. What? This is all that you people need to remember and make it yourself. Okay. Now, okay, everyone. This is something that you should have derived on your own. I have been writing like this since when? Okay. L1, U2. You should have said this to me, sir. It is I love you too. Khatam. Simple. Okay. Now you will never forget for the rest of your life where the spinal cord ends. Done. That's how you remember things in life. Okay. Sorry for these mnemonics, huh? But that's how the mnemonics how you remember in life. Right? I mean, there is no concept here now. It is something that you need to by heart or mug it up or just rote learning. It's fine. So, I mean, that's what I said. L1, U2. Just change it into I love you too. Okay. That's it. Now, the point is that is the reason when you want to give spinal anesthesia, you're never giving it at that level, right? Because the spinal cord is getting over here, which is the lower border of L1 and the upper border of L2, right? In a child, it goes to the lower border of L3, right? Another question. I told you na question aata hai. Let me ask you one more question. If this is the point, then tell me where does the dura end in a child, not in adult? S1, S2, S3, S4. Where does the dura end in a child? This is A, this is B, this is C, and this is D. Again, this is asked in the exam. Where does the dura end in a child? Important question, guys. So spinal cord and dura, both are important. Dr. Harsh says lower border of S2. Anyone else? S3, S4. Correct. Dr. Khan has said correctly. It is S4 in a child. And Dr. Mohammed Shahid says, I am from KGMU. King George, Lucknow. Very nice, Dr. Mohammed Shahid. Welcome, welcome. Dr. Khan says S1 to S2. Correct. That is in an adult. Absolutely correct. Okay. S2 is an adult, right? So remember, dura in adult is S2. In a child is S4. Spinal cord in adult is lower border of L1, upper border of L2. In a child, it is lower border of L3, right? For adult, I told you, I love you too, right? That's how you remember. Okay. Child के लिए lower border of L3. This is an important question. Anatomy question or anesthesia question. This is how you remember, and this becomes very important that you need to know, right? So spinal cord and dura. Both the questions we finished over here. ठीक है. Sorry यार, questions के ना answer ऐसे याद होते हैं, and that's how I teach also. All of you. That's how I teach. ठीक है. Not teach. I'm just sharing. Who's teaching? I'm just sharing my knowledge. I may be wrong many a times. Okay. Next question. Okay. Dr. Mohammed Shahid says S3, S4. Correct. So Dr. Mohammed Shahid is KG. You're preparing for NEET PG then, Dr. Mohammed Shahid? हाँ हाँ, स्लो टीचिंग नहीं, ये तो शेयरिंग ऑफ नॉलेज है यार. डॉक्टर शाहिद जी. चलो आंसर. IV anesthetic agent of choice for cardiac patient. Propofol, ketamine, etomidate, sevoflurane. Important question. This has been asked 2 times in the last 4 years. Yeah. According to me. Huh? According to me. Dr. Khan says one answer. Right, other people, jaldi. So this is where I'll cover the IV drugs with you, like how we covered inhalationals yesterday. All of you remember, we took that chart where we discussed drug of choices. So similarly, we'll try to see here also the drug of choice. Okay. So IV anesthetic agent of choice for cardiac patient. So Dr. Khan has given an answer. Baki log, other people, jaldi. Dr. Khan says A or C. You know, you people are giving good answers in CPR. Let me tell you. Yesterday, when I said discuss with you, na, you people have given me good answers and correct answers in oxygen delivery. All of you who attended, right? You gave me correct answers with CPR. So you people were good with oxygen delivery and CPR. But yesterday also, when I was discussing inhalational, guys, there was slight problem when we were discussing things out. And today also, see, it's a simple question. And again, there's a problem. Guys, you please read Pharmac. The ones who are attending right now with me. Okay. I'm sure that you will be correct with the oxygen delivery devices. So don't read it again. You people, I think, know it, the answers. CPR, I think you people are good according to me. I think you're aware of the facts. How do I going ahead? Pharmac, please pay attention to inhalationals and IV. It's not that questions will not be asked, but I find it that, you know, you have to read little bit. Am I right? All of you? This is where you are getting confused now. Pharmac. Yes. See, I can see that. That's what I'm telling you. Hence, I made you write the inhalationals yesterday. That was a last minute revision just before you go for the exam. If you remember, I made you write down. Similarly, we'll do that today. Remember, propofol decreases everything. It decreases the blood pressure. It decreases the heart rate. It decreases the cardiac output. Right. So, can you use it in a cardiac patient? Yes, you can use it, except if a patient is in shock or if the patient is in hypovolemia. Right. Because जिसका BP already कम है, उस पेशेंट का बीपी और कम करोगे तो मर जाएगा ना. The patient will be dead. Someone's BP is already less and you will give him propofol, the patient is gone. So therefore this drug can be used. I'm not denying, yes, it can be used for a cardiac patient except for shock and hypovolemia. Ketamine, on the other hand, remember, it increases everything. Ketamine increases, so it increases the BP, it increases the heart rate, it increases the cardiac output, it increases oxygen consumption. Why do you want someone's heart to increase oxygen consumption? If ketamine is a drug that increases oxygen consumption, it means this drug is going to put more stress on the heart. So in a cardiac patient, will you use it? No. Ketamine is in fact not to be used in a cardiac patient. The only place where you use it, if a patient is in shock and you want to increase the BP, then you can use it. Or if the patient has got tetralogy of Fallot, this is the only place where you use ketamine in the cardiac system. Rest, etomidate is an important drug that you people need to know. No change in blood pressure, no change in heart rate, no change in cardiac output. This drug basically maintains cardiac output. So if you have a cardiac patient who's having a problem, you don't want the heart rate and BP to change. You don't want the cardiac output to change. You don't want consumption to change. Therefore, in cardiac patients, etomidate becomes the drug of choice. Okay. I tell students, remember like this. Etomidate, remember it as ecomidate. It's a drug which maintains cardiac output. Etomidate ko remember it as ecomidate. It maintains cardiac output. Therefore, it is a drug of choice in the cardiac patients. Thumbs up, everyone. Sevoflurane is not a IV drug. Sevoflurane is an inhalational agent. And even if it was an inhalational, yesterday we discussed, in inhalational also, isoflurane is what is supposed to be used in a cardiac patient. Okay, and not sevoflurane. Okay, everyone? Right. So the correct answer here is etomidate. Etomidate. Ready? Thumbs up, guys. Okay, Dr. Khan says yes. Okay, so I got one thumbs up from all of you. Hopefully this point is clear. So let's do one thing here. Okay, Dr. Tech with Alex also says thumbs up. So let's do one thing. As we were discussing yesterday, remember, if we have to talk about the drugs, ketamine. Okay, where is ketamine used? I just discussed with you where is ketamine used because of increase in BP and all. So the only place where it becomes drug of choice is in a patient of shock, right? In a patient of technology of fallow or shunt, and it is a drug of choice in full stomach patients. Plus, ketamine is one of the drugs which is used in out of OT anesthesia or short procedures where you can use it. हाँ, shock right, Dr. Khan. ठीक है, ये हो गया ketamine का. Then if you talk of etomidate, it becomes the drug of choice for a cardiac patient, cardiac surgery, right? It becomes a drug of choice in the cardiac system. Then if there's a drug called methotrexatol, this was supposed to be the drug of choice for ECT in psychiatry, right? Methotrexatol. Then you have thiopentone. Thiopentone. So there's one point here. A lot of people say, see now thiopentone is a barbiturate like phenobarbital. इसके लिए, according to me, for any CNS case, right? Any CNS case, thiopentone becomes a very good drug because it has cerebroprotective properties, right? So according to me, for any CNS case, thiopentone is one of the best drugs. Apart from that, if you want to decrease raised intracranial pressure, it becomes one of the drugs, right? Okay, one more point, ketamine, important, I didn't write. Ketamine, apart from that, is used in respiratory patients. Patients who are having bronchospasm, because it's a good bronchodilator drug. And for kids, pediatric, remember K for ketamine, K for kids, right? If a child lets you take an IV cannula, you will prefer to use ketamine. So in a respiratory patient who's having bronchospasm, here you will use ketamine, and for kids you can use ketamine. Thiopentone, apart from used in CNS, it can decrease the raised intracranial pressure. It can be used for treatment, non-anesthesia use as a status epilepticus. So these are non-anesthesia uses, and also for narco analysis. Truth serum. Rest. Everywhere else it is propofol. Rest. Everywhere else it is propofol. That is how you remember. Everywhere else, whatever you think, rest, everywhere it is propofol. It's one of the ways, simpler ways that you can remember, because propofol is used everywhere. You talk ICU sedation, you say porphyria, everywhere there's going to be propofol, everywhere. Okay, so propofol, apart from what is being mentioned here, everywhere propofol becomes drug of choice. Everywhere, you name it. Malignant hyperthermia, porphyria, yes, even Dr. Med Psycho, daycare surgery also. Everywhere, whether you talk daycare surgery, you say routine induction, routine maintenance, liver case, renal case, you take anything, it's going to be propofol. Okay, apart from what we mentioned, ketamine in shock, tetralogy of Fallot, full stomach patients, out of OT anesthesia, short procedure, and respiratory patient with bronchospasm. In fact, if a respiratory patient is without bronchospasm, that again you will use propofol. In fact, a lot of people are now trying to use propofol for pediatrics also, but it's not said no. But we still prefer to say that for pediatric patients, use ketamine. But apart from what we have mentioned, everywhere else propofol, whether you take ophthal, whether you take malignant hyperthermia, you take ICU sedation, you take porphyria. In fact, it is anti-emetic drug, it is anti-pruritic drug, it's an antioxidant drug. Okay, you name it, yeah. You name anything, it's all propofol, propofol, propofol. List is endless. If I say liver, daycare, renal, I mean the list is endless. Rather than me saying something, remember everywhere else it is propofol. Thumbs up, guys. Remind me to save it, huh? All of you, that is on your head. You people have to tell me to save it. Okay, so these are the basic drug of choices that I would like to discuss with you, right? And everywhere else it is propofol, apart from what we have mentioned. Any questions and doubts, please ask me. Even daycare, I'll say even daycare, even liver, even renal. Everywhere it is propofol, 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 ICU sedation, porphyria, you name it. Whatever comes in your mind, name it. It's going to be propofol. Okay? So these are all the IV drug of choices. According to me, I'm sharing my knowledge. I'm saying my disclaimer in all the points. Huh? Otherwise, people say, sorry, you're wrong here. Yes, I may be wrong. But this is a small way to remember. This is a small way to remember all the drug of choices pharmacology. Okay. Now, this was asked in FMGE in 2021. The same question, the same way. A sick patient is in the ward, needs supplemental oxygen. It will be given from which of the following cylinders? They gave you four images, and one of the questions was asked like this: A, B, C, and D. Which image is oxygen cylinder? Simple question, common question. It has been asked. This was a question during the COVID times. Okay. Dr. Vikas, Dr. Harsh, Dr. Khan, डॉक्टर मेड साइको, ठीक है, सबने करेक्टली बोला, ये है बी. डॉक्टर टेक विद राइट. ओके, तो क्वेश्चन, व्हाट इज सी? What is C? Let me give you the options then. Let's ask the next question. What is C? C is air, C is carbon dioxide, C is helium, or it is nitrogen. A, B, C, and D. Next question. What is the cylinder, this one? Is it this? Is it this? Is it helium? Or is it nitrogen? This cylinder. Dr. Khan says CO2. Dr. Statistic. Good name यार. Statistic. तुम लोग के नाम भी बहुत अच्छे होते हैं, मैं हर बार बोलता हूँ. Every time I get to know something new and different and nice. Dr. Statistic. Dr. Educated Drug Dealer. Here in front of you. Sorry. Even I should have a name for myself, ना. तुम लोग ऐसा अच्छा नाम रखते हो, मेरे को नहीं मिलेगा. My class will come as Dr. Vinish. Okay, the next is by Dr. Vinish. I should also write. Next class is by Dr. Educated Drug Dealer. Okay, all of you are right regarding this point. This is a cylinder of carbon dioxide. So remember, the cylinder colors and pin index are all important. Okay, so the first cylinder, this you see completely gray in color. This is carbon dioxide. So remember, carbon dioxide is gray in color, and the pin index number is 1, 6, and 2, 6. Right? When you see the next one, okay, so this one which you see, this is what is called as the cylinder of air. Air. So air is basically gray in color and it has a white shoulder, right? And the pin index is 1, 5. The next cylinder after that which you see is oxygen. Oxygen is black in color and it has a white shoulder. The pin index is 2, 5. I think all of you know it. I'm just revising it again. I think all of you already know it. All of you already know it. Okay. The next one is nitrous oxide cylinder. This is completely blue in color and the pin index is 3, 5. The last one that you see, this is Antonox. Antonox is basically blue in color with white shoulder. The pin index number is 7. These are, if you have to ask me which are the ones you need to remember, always remember this: air is important, okay, oxygen is important, and nitrous oxide. These three you cannot forget. Air, oxygen, and nitrous you can't forget. Okay. Entomology नहीं, डॉक्टर मेड साइको अपने आप ऑटो करेक्ट हो गया डॉक्टर मेड साइको का. It is Antonox as he was saying, right. Auto correct हो गया था while typing. You people are typing fast ना. Okay, and someone had said helium also. Absolutely correct. Helium or heliox. The color is basically brown. Heliox is the one which is used. So heliox is basically brown in color, and then pin index would be 2, 4, brown with white. 2, 4, and 4, 6. So these are all the pin index numbers. Helium is not that important, guys. Right? This is helium, brown in color, 2, 4, and 4, 6. Correct. But helium is not that important. Okay. So these are all the pin index numbers. Apart from that, and the color also, color of the cylinders. Yesterday we had discussed. These are the pipelines. Okay. Anyone? Which pipeline is this? What is this pipeline? Image based diagram. Okay, options I haven't given you. Oxygen, nitrous, vacuum, कार्बन डाइऑक्साइड, एयर. ओ 5 ऑप्शन आ गए. चलो ठीक है. It's okay. Which is this pipeline that I marked? A, B, C, D, and E. I'm giving you 5 options. Huh? It's okay. These are the pipelines which you see all around the hospital. Dr. Vikas ने एक आंसर दिया. Dr. Vikas has said air. Sorry, that's how I discuss. I know. Newer questions we are making, but that's how questions come in the exam, right? This was not a part of the question that we had planned, but we are doing it. Dr. Vikas ने आंसर दिया. बाकी लोग, other people? Dr. Khan has said B. Dr. Khan, B कैसे आएगा? B में तो नाइट्रस लिखा है. नाइट्रस का कलर क्या होना चाहिए? If you get confused between C, D and E, I understand. You should not be confused between A and B. Guys, remember this point. See, I had pointed towards this, na? This is black in color, so it's important. Chalo, good. So we will discuss. अरे नाइट्रोजन नहीं है वो, एयर है, एयर. That is air. Absolutely correct. Dr. Vikas D has said that correct answer. So let's write this down, guys. Remember, when you talk of pipelines, the white colored pipeline is oxygen. The blue colored pipeline is nitrous oxide. The black color is what you see is air. And you people have not seen it so often because this pipeline lies in the OT or it lies in the ICU. In the ICU, the ventilators run on compressed air. और OT में हम लोग इसको यूज करते हैं wherever nitrous oxide cannot be used. That is why you find it only inside the OT and ICU, the black pipeline. And what is this yellow used for? Yellow is basically vacuum, which is used for suctioning of a patient. So these are the pipeline and the colors, guys. So remember, I'll be just writing it down because ये भी important है. Oxygen pipeline is always white in color. ठीक है? Nitrous oxide pipeline is always blue in color. Air pipeline is always black in color, and this is called vacuum, which is yellow in color. Oh, Dr. Khan, it's okay, it's okay. Dr. Khan, fine. Maybe I did not mark it properly. My fault also. Sorry, no issues. And it can be because of how I mark. Now you people must be seeing on your mobile. It must not be visible. That's okay. But my point is to have the proper revision of all these points and concepts which are important according to me from the exam point of view. Small things here, and this is not the time to discuss with you what is minimum alveolar concentration. No, this time is just to revise our previous year's questions. Whatever we have done, we should focus only on that. What we have not done, no new concept. I mean, of course, if there's a lot of time, we'll do that again. I'm not denying, but this is just a revision point where we are doing the previous year's questions, right? Vacuum is always yellow. So hopefully these points are clear, guys. Okay, vacuum is this which is used for suctioning of the patient. Any questions and doubts, ask me. So this vacuum is basically used for suctioning. It is present in the wards, ICU, OT, everywhere. But this black one is present only in the OT and the ICU, not anywhere else. Okay. Nitrous is there only in the OT, and oxygen is there in throughout the hospital. In fact, even suction is throughout the hospital. All throughout the hospital, you will find this vacuum also. Okay. This part will not be asked in the exam. This was additional information so that you people come to know, but the colors are important. Next question. This was a question asked in 2021, right? This was a June question, I remember. And this is a difficult question. And this question was not expected from FMGE. This, if you will ask me, is an INICET level question. But they had asked this question. So whenever they are asking, you can't say anyone why they are asking a question. You're supposed to know the answer. But if you don't understand the concept behind it, it is okay. Okay. But this question was asked in 2021 June. 2021 only. No, 2020. No. When was COVID? COVID was in 2020. So this question was in 2020. 1. I think so. I'm not sure. Because even then, when I looked at the question at that point of time, my reaction was, I have discussed this question before also on YouTube. Huh? It's there. But even then, my point was, why are we discussing this concept for FMGE? But yes, Dr. Med Psycho, absolutely correct. Absolutely correct. The correct answer is negative pressure pulmonary edema, as Dr. Med Psycho has said. Okay. This is the same question which came in the exam. So a young patient underwent a surgery under general anesthesia with oxygen, nitrous oxide, and desflurane. Just after extubation, means the surgery is done, surgery is over. When the patient was extubated, you took out the endotracheal tube and suddenly the SpO2 decreased. Suddenly. Then you started auscultating the patients and there were crepitations, right? Crepitations or same are called rals. You get that noise you get. It's a noise like this, You take a paper and you crush it. It's that kind of noise. See, there's a difference between rhonchi and creps. What is the difference between rhonchi and creps? Rhonchi jo hota hai na, you get to hear like this. That noise which you get na, that is rhonchi. Creps. डॉक्टर नॉक्टर्नल गाय से सर इज लाइक हार्दिक पांड्या. करेक्ट यार, डॉक्टर नॉक्टर्नल गाय मेरे को बहुत अच्छा लगता है सुन के. व्हेन समवन सेज हार्दिक पांड्या, देन आई थिंक अबाउट हिज मैरिज. ओके, करेक्ट. हार्दिक पांड्या, इंस्पिरेशन, गुड लीडर, राइट, प्लेइंग वेल, गुड इन ऑल द फील्ड्स, ऑलराउंडर. Who doesn't like Hardik Pandya, right? Dhoni, Hardik Pandya. Anyways, coming back to what we were discussing, not Hardik Pandya, but our question. Okay, rhonchi and creps. So, as I said, rhonchi is that noise that is of bronchospasm, and creps is that cut noise which you are getting. Okay, so crepitations means there is some fluid, right? Some fluid which is making the noise. Rhonchi means there is some bronchospasm. Okay, rhonchi means there is some bronchospasm. All right, so here we are discussing crepitations. So what are the conditions here that you think there may be fluid which is giving rise to cut? First is pleural effusion. So all of you will say, sir, pleural effusion is fluid. Yes, it is fluid. But when pleural effusion is there, guys, what happens is pleural effusion will push the lung like this, and because of the fluid in the pleural space, the air entry here decreases. You don't get crepitations. It's very rare. I haven't heard. If there are people who must have heard, I don't know. But whenever there is air, whenever there is fluid, when you get in the lungs, in the pleural space, when you're getting fluid, so this will lead to decreased air entry because your lung has got shrunken, na? Lung chota ho gaya. Lung chota ho gaya hai. So because the lung has decreased, this part will have no air entry. So when you auscultate that part of the lung, the air entry there decreases. There's not going to be crepitation. So pleural effusion is out. Okay. Then ARDS and negative pressure pulmonary edema, both of them have fluid. Correct. If you have a confusion between them, it is correct. The last point is atelectasis. What is atelectasis? It's a collapse of the lung. Collapse of the lung. Okay, so there can be contraction, resorption, or compression. So it's again collapse of the lung which is there, which can be obstructive or due to pressure on the lung. So even when there is a collapse that you're getting, atelectasis you're getting, there are no crepitations, I think, which you're going to find. So our 2 points where you're going to get confused is ARDS and negative pressure pulmonary edema. Now the point is ARDS. What is ARDS? ARDS is when you have some fluid collected, right? So ARDS is like this. Fluid is collected in the alveoli, right? It is getting collected. But this is basically taking place because of some infection. Alright, so patient would have infection. Patient would have maybe COVID. Patient would have maybe sepsis, right? Patient is having pneumonia, or something which is leading to ARDS, mostly something of like that sort of a thing, something leading to that over a period of time, not immediately. Now what has happened is during the surgery, patient was fine. Immediately something has happened. Immediately at that moment, what has happened? That is what is called as negative pressure pulmonary edema. What is negative pressure pulmonary edema? Negative pressure pulmonary edema means, imagine this is the vocal cord, right? Here is the trachea and this is going to the lungs, right? Right? It is going to the lungs. Sorry, my lungs are also looking like heart. Now, so what happens is, basically, you have extubated the patient. So patient's endotracheal tube, which was there, I've taken out. But now the patient is unable to breathe, and instead of the vocal cords, vocal cords are open like this, and vocal cords, when they close, it becomes like this. So imagine what has happened now. Vocal cords have closed. So can you see it has become a negative pressure, a negative pressure, a negative pressure. This increases the intrathoracic pressure. I'm not going to go into too much details, but in short, just try to think. अंदर का pressure increase हो रहा है, increase हो रहा है, increase हो रहा है. Suddenly what happens? Whatever fluid is here, that fluid enters inside the lung. Okay, because of the high intrathoracic pressure, because patient is trying to breathe against a closed glottis. ये जो vocal cord है, this is closed, right? So patient is trying to breathe against, imagine your lungs are here and you're trying to breathe with vocal cords closed. Vocal cord बंद है, how will you close? Intrathoracic pressure is increasing, तो कहीं ना कहीं तो it has to open. If the vocal cords don't open, what will happen? Fluid gushes in. Understood? That is what is causing. Don't go into too much details. Just think it like this. You're trying to breathe against closed vocal cords. There is no opening. Basically, vocal cords are not opening. For inspiration, vocal cords have to open. Air going inside, carbon dioxide coming outside, but vocal cords are closed, tightly closed. So you are trying to breathe with vocal cords closed, and pressure gives way. It causes negative pressure pulmonary edema. Okay? So the correct answer is negative pressure pulmonary edema. Thumbs up, everyone. Is it clear? You people gave me the correct answer, but ideally I will say it is INICET question. But still, if you know, I've understood the concept, well and good. Okay. Let's not go into too much details. If there's any doubt, please you can ask me. Right? अरे किसी को doubt नहीं है? So let's take the next question. Dr. Med Psycho says in child. In child, yeah, it's more common. Yes. Of course. But in anesthesia, during extubation, it can be. Correct. Vocal cord closed and you're trying to breathe against a closed glottis. That's what you're trying to say. The next question. So Dr. Khan is ready with fastest finger first. Okay. Immediately. Answer. Which is good, huh? Which is good. So, which of the following structure is not encountered during epidural anesthesia? Supraspinous ligament, interspinous ligament, ligamentum flavum, and dura. Dr. Vikas D has said dura. Dr. Khan has said the same thing. Dr. Med Psycho says dura. So I think all of you are agreeing with me, and all of you are saying dura. Let's mark it. That's the correct answer. Okay, dura. Absolutely correct. Okay. What are the layers? That becomes important. Okay, in this, when you're giving epidural anesthesia, right? Epidural. So we are just discussing them in one by one. So I know there are a lot of mnemonics for this also, but rather than mnemonics, I'll just say if you can think about it like this. The first thing that you get is the skin, and after the skin immediately is going to be the subcutaneous tissue, right? So when you're giving spinal, when you're going from the back of the patient, the first layer that you get is the skin. After skin comes the subcutaneous tissue. So this is the skin, then comes the subcutaneous tissue, right? So skin, subcutaneous tissue. After that, you're going to get a layer which covers up the spinous process, correct? So this is called as supraspinous ligament, right? After that, you get a layer in between the spinous process, correct? So this is called as interspinous ligament. And then you're getting one more layer, which is a ligament over here. And this is called as ligamentum flavum. So if you have to see the ligaments, so the first was the skin, subcutaneous tissue. Then you got this thing, which is called as the supraspinous ligament. Then there was interspinous ligament in between the spinous process, and then you came to ligamentum flavum. As soon as you cross ligamentum flavum, we come to this place, which is called as the epidural space. You have not reached the dura yet. Epidural has come, hence it is called epidural, outside the dura. Epidural, extradural. Epidural is also called as extradural or outside the dura. After your ligamentum flavum, you have got epidural space, right? Then comes the dura, then comes the arachnoid, and after, if you can see this small layer that you see, this is the dura, and the layer after that is the arachnoid, and after that, this area which you see, this is the subarachnoid space, and this is what contains the CSF. So CSF lies between which two layers? It lies between the pia and it lies between the arachnoid. Okay, so these are the layers, and when you give your spinal anesthesia, it's given here. You have to puncture the dura and the arachnoid and then reach the CSF. So these are the layers that we see. So what layers are there? The first layer that you get is the skin, then you get is the subcutaneous tissue. After that is the supraspinous ligament. Then you get is the interspinous ligament. Then what we get is ligamentum flavum. Then what we get is ligamentum flavum. After ligamentum flavum, what you get the next after ligamentum flavum? So supraspinous ligament, interspinous ligament. There is ligamentum flavum. After ligamentum flavum, right? After ligamentum flavum, the next thing that you get is your epidural space, right? After the epidural space, you get the dura, then you get the arachnoid, and after that you get the CSF. So CSF lies between two layers, arachnoid and pia. Okay, so these are all the layers. So this is about your epidural, and this is where you do the lumbar puncture, okay, or spinal. So this is the same thing, correct? So it comes after the arachnoid. So epidural, then dura, and then arachnoid. Hopefully all these points are clear to everyone. Clear? So this was about the spinal and epidural. This is yesterday's question only. Okay, we have already done it, correct? And in endotracheal tube, what determines the resistance? We have already done it. It's the diameter or the radius. This was again a question which was asked 2 times, as I said, in the last 4-5 papers. Next, which of the following anesthetic agent is best for a cardiac patient? So any question about spinal epidural, please ask me. Okay. Otherwise, we have taken up the next question. Which of the following anesthetic agent is best suited for a cardiac patient? हाँ डॉक्टर विकास, वो तो डायमीटर था, उसमें आंसर वो हम लोग कल डिस्कस कर चुके थे. But if you want, I can just discuss that again. See, as we had said, if a tube is big, right, then the resistance to the flow which is going, right, the resistance will not be so much. This much is the going, it's the resistance. Then there is, because the tube diameter is more, the area is more, then you're going to get less resistance. But if you have reduced the diameter, if you have reduced this point, imagine all the things now, this much flow is supposed to be going here, and that flow now goes against increased resistance. So as it is getting smaller in diameter or radius, the resistance increases, and this was the physics behind it. The physics is this, right? Physics is this. The resistance is inversely proportional to the radius or the diameter. Right? This is what we had discussed yesterday. Now next question, and I think all of you have given me the correct answer. Dr. Khan, Dr. Med Psycho, अरे बाकी लोग correct. Isoflurane, which I discussed a while back. Okay, so in a cardiac patient, remember, in a cardiac patient, halothane is normally not used because it decreases the blood pressure, right? It decreases the heart rate also. It decreases the contraction of the heart, and it can also cause arrhythmias. So halothane is contraindicated in a cardiac patient. Nitrous oxide, slight increase and decrease, it can be used, but it's not a drug of choice, I'll say. Sevoflurane can also be used. Yes, sevoflurane can also be used in a cardiac patient, totally acceptable, but where? Which brings me to the next question. There's one more question based on that. Okay, isoflurane, remember, it maintains the cardiac output, and it is a coronary vasodilator. Okay, these are two properties because of which you can use it. But being a coronary vasodilator, guys, it has a side effect. What is it called? Anyone? Side effect, and that is one of the side effect of isoflurane, because of which sevoflurane is used in cardiac patients. Have you heard of something called as coronary steal phenomena? So isoflurane is known to cause coronary steal phenomena, which is normally seen in ischemic heart disease, myocardial ischemia, angina. So in these patients, a lot of people are saying if a patient has myocardial ischemia, ischemic heart disease, in those patients, because there can be a chance of coronary steal, this is seen with isoflurane, it's better to use sevoflurane. And that is why in these conditions, sevoflurane might become the drug of choice. But remember, most of the times for a cardiac patient, always remember the best drug is isoflurane. Okay, let's not go into so much details about that coronary steal and sevoflurane. Just remember, isoflurane has one side effect in the coronary system, which is called coronary steal. Okay, coronary steal phenomena, because of which a sevoflurane can become a drug of choice in MI, patients of myocardial ischemia or ischemic heart disease. Okay, just that much. Rest all the drug of choice I have discussed with you yesterday, and we have written it on the that paper that we have shared yesterday on the Telegram group. Okay, guys. Any questions? Ask me. Otherwise, we'll go to the next question. Yes. Any questions or doubts? Anyone? No? So may I go forward then, all of you? Dr. Med Psycho says due to signal in last epicardial artery. Dr. Med Psycho, correct. I'm not going to go into too much details. I'm not going into the details of that coronary steal. You're absolutely correct regarding that. Okay, absolutely correct. Because remember, अच्छा, one more point. This coronary steal का question आता है ना? Coronary steal is seen with 3 drugs. Coronary steal phenomena is normally commonly seen with isoflurane is one drug. Remember, there is hydralazine and dipyridamole also. ठीक है, ये सब एग्जाम में पूछा हुआ है. These are pharmac drugs. ठीक है, there are other drugs also from pharmac, other drugs also which cause coronary steal, the coronary vasodilators, but these are the ones which are more commonly causing coronary steal compared to others. Okay, coronary steal phenomena. Next question. Halothane causes malignant hyperthermia by affecting which channels? No one should be wrong. I discussed this yesterday only. Important question. Halothane causes malignant hyperthermia by affecting which channels? Yes. Dr. Khan has given an answer. बाकी लोग जल्दी. Dr. Med Psycho, Dr. Vikas. ठीक है, चलो, let's take the answer correct. It's the calcium channel. Okay, halothane causes malignant hyperthermia by affecting the calcium channels. Correct. So as I discussed, not going into details, it's a genetic disorder of the sarcoplasmic reticulum, ryanodine receptor gene abnormality, which is a calcium release channel. Correct. I'm not going to go into details. So basically, disorder of calcium release channel. Baki I have discussed it yesterday. We have written on the paper also, and you people will be having the PDF with you. Treatment is dantrolene, which stops the calcium release. And if the patient is malignant hyperthermia, the drugs to be used in this patient are propofol and procaine. For local anesthesia, procaine. For general anesthesia, propofol. Okay, that's a short revision for this. Done. Next. Okay. A COPD patient in ICU was on oxygen therapy with mask of 2 liters. He was found to be hypoventilating. His PCO2 on blood gas analysis was 64. What is the best strategy for this patient? Again, this was again asked in the same year. Not a very, very good question for FMG, I'll say. But nowadays, you know, that line is very blurred. I can't say it's FMG question, it's INICET question. So we can't say the line is blurred. Some questions are easy, some are difficult. This is one of that. Okay. A COPD patient is in the ICU. He is already on oxygen therapy with mask with 2 liters of oxygen, right? He is found to be hypoventilating. His PCO2 on blood gas analysis is 64. What is the best strategy for this patient? Increase the FiO2. डॉक्टर खान डॉक्टर मेड साइको से देखो ये डिफरेंस है थोड़ा सा. ये मैंने कल भी डिस्कस किया था. इफ यू रिमेंबर आई वाज डिस्कसिंग अ कंसेप्ट वेयर आई हैड डिस्कस्ड, यू नो, इफ यू टेक आउट yesterday's PDF, I have written the answer in yesterday's PDF only. If you will see, yesterday's PDF has that answer. Okay, according to me. Let disclaimer. Disclaimer. What is a disclaimer? I may be wrong. I am just discussing my point of view and my knowledge. That is the disclaimer. Okay, keeping the disclaimer in mind, let's understand what is COPD. COPD is a condition in which anyways there is retention of carbon dioxide. It's chronic obstructive pulmonary disease. Basically it's obstruction, chronic obstruction. It's obstruction taking place because of which carbon dioxide is not going out. So patient has got accustomed to CO2 being slightly high, but here CO2 is more high. Okay, and these patients are always supposed to be kept little bit hypoxic. They are to be kept little bit hypoxic, so they have the tendency to breathe. Increase the FiO2 is wrong. Yesterday we were discussing asthma patient, if you remember, and I told you asthma patient ka saturation is 88%. You will have to give oxygen. Right? You have to give oxygen. There's nothing that you can do there. But this is a COPD patient. For a COPD patient, if you increase oxygen, it becomes detrimental, because more oxygen will increase the carbon dioxide. It will lead to more CO2 retention. And more CO2 retention means patient will stop breathing. It leads to CO2 retention if you increase the FiO2. So increasing the FiO2 is totally out. Totally out. Okay, it is not a correct answer for COPD patient. 2 liter is less, I agree. It is okay, we'll maintain on that. Decreasing the FiO2, yes, you may think. Intubating the patient and put on ventilator, yes, you can think. But the best thing to do for this patient is start BiPAP. In fact, yesterday also I mentioned, when you are discussing asthma, I said in COPD you have to take a call. Of course, you would want to intubate a patient, but if you intubate COPD patient, they don't get extubated easily. So COPD patient, the best thing is non-invasive ventilation, BiPAP or CPAP. Okay, and BiPAP is almost more better. It is bi-level positive airway pressure. Okay, so it is bi-level positive airway pressure. In fact, BiPAP is always better than CPAP also. In fact, CPAP you people must have heard as a treatment of the obstructive sleep apnea syndrome also. This BiPAP is used for COPD patients. So all the three options can be done. Decreasing the FiO2 further, yes, it is possible, but anyways CO2 retention has taken place. So my aim is basically, Dr. Med Psycho is confused. Confused in what, Dr. Med Psycho? हाँ, थोड़ा confusion तो है. Okay, so where is the confusion? You tell me. ठीक है, थोड़ा सा डिस्कशन कर लेंगे इसके ऊपर. Let's discuss it out. See, if you talk of COPD patients ना, see, COPD patients का सबसे बड़ा प्रॉब्लम होता है that they have carbon dioxide retention. ठीक है, and COPD patients need to be kept hypoxic. Right, hypoxia for them is a stimulus to breathe. अगर COPD patient को you give more oxygen, in that case they will stop breathing. So therefore, in any COPD patient, to increase oxygen beyond a level does not work, because it will stop their breath. So the first option is out. Hopefully you have understood this point. The next are three things, which is decrease the FiO2, BiPAP, and intubate and start on ventilator. Right. So out of the three options, I am discussing the last option first. Okay, let me discuss the option B. Why don't we decrease the FiO2? अरे patient तो already 2 liter पे है. Only 2 liter. If you remember, 2 liter का मतलब होता है, yesterday when we were discussing oxygen delivery devices, do you remember? Oxygen delivery devices, we remembered nasal prongs. This is the only device which works between 1 to 6 liters. If you use a face mask, it works between 5 to 10 liters. which means our patient is already on nasal prongs of 2 liters oxygen. Means इतना छोटा सा ऑक्सीजन चल रहा है, उससे कम क्या दोगे? How can you make it even less than 2? It is ideally not possible, because at then his saturation will start decreasing. Correct, but you're not getting the point. A COPD, see, that is the whole point. A COPD can tolerate hypoxia. A COPD patient has to be kept little hypoxic. That's what I'm trying to say. See, COPD patient में there is something called as permissive hypercapnia. अरे इतना डिटेल में नहीं जाना यार. Remember one thing, COPD patients का, let me speak in हिंदी जैसे, COPD patient का क्या होता है, उसका ऑक्सीजन थोड़ा सा कम रखना होता है, which is okay. They will survive. If we said asthmatic patient yesterday ना, asthma patient 88% में can die immediately. But COPD patient with 88 and 90 can survive. That is the difference. It is because of the pathology. That is how they are. Okay. Asthmatic patient at 88% will go away. But COPD patient at 88-90 will still survive. Their low saturation because the lungs are damaged. See, that's why it is called chronic, na? It is chronic obstructive pulmonary disease. Wo basically, he's an old patient. See, asthmatic patient can be a 6-year-old child, right? But a COPD patient is not a 6-year-old child. COPD patient will be 60-year-old male, 60-year-old female. So what happens is their lungs have become accustomed to hypoxia. Their lungs have become accustomed to CO2 retention. If you give them more oxygen, वो breathing बंद कर देंगे. You are supposed to take out their CO2 and maintain little levels of hypoxia. इसलिए इस patient को बहुत oxygen नहीं देना होता. It's the pathology of COPD, right? Decreasing below 2 liters, I think it does not make sense. The only two options left with us is start BiPAP and intubate. If this oxygen flow was 4 liters or 6 liters, I could have said come down to 2 liter. But already 2 liter means minimum flow is going on. अब 2 से कितना कम करोगे? Already patient must be on nasal prongs only, na? That is the only thing working at 2 liters, because face mask is also not working. It's even lower than that, that normal nasal prongs, nasal cannula. So therefore, the two options left with you are a 60-year-old patient where you want to start BiPAP, or a 60-year-old patient who you want to intubate. Just like in COVID, when you had realized that, COVID patients, as soon as they are intubated, they die. Do you remember? In COVID, they used to say, a patient of COVID, if you intubate, they are dead. So try not to intubate a patient, put them on BiPAP and CPAP. And the same thing holds true for COPD patient. If you intubate them, they don't come out. So therefore, the correct answer here should be put the patient on BiPAP, which is a non-invasive ventilation. Intubation means you're putting a tube inside the trachea. So therefore, for this patient, the better would be that you put a BiPAP, which becomes a non-invasive ventilation. Thumbs up, guys. It's not invasive. You're not putting endotracheal tube, because BiPAP goes from a face mask. BiPAP does not go from endotracheal tube. BiPAP goes from a face mask. Okay. Okay, everyone. Dr. Med Psycho, okay. Right. Anyone else doubts? I told you that it's going to be a difficult one, because here you need to understand the concept of medicine also, right? Apart from knowing the ICU strategy over here. So hopefully you've understood, right? Right. I got a thumbs up from Dr. Med Psycho. Dr. Khan said got it now. Thank you, Dr. Khan. Chalo. When you people say that, na, I like it. मेरे को अच्छा लगता है. That hopefully you've understood. And I'm just sharing my knowledge. Huh? Maybe there are other people who might disagree with me. Disclaimer, as always. I'm sharing my knowledge as what I would do in my clinical practice, and from the knowledge that I have. I'm just sharing. No one can say I'm always right. I can also never say I'm always right. Okay. Next. Action of local anesthesia agent is by blocking which of the following ion channels? Important question. I'm just thinking something about this question, what happened in a class, and I'm smiling. Okay, I'll discuss with you. I'll share with you. Dr. Med Psycho has given answer. Remind me, I have to share that point with you. Dr. Med Psycho and Dr. Khan. अरे बाकी के लोग आंसर नहीं दे रहे. There were so many other people ना. Dr. Khan, Dr. MedPsych were the only ones cut करके they're typing also and they're messaging also. Correct. Both of you are absolutely right. The people who gave me the answer. Okay. Sodium channel. Absolutely correct. Okay. So when you speak of a local anesthesia drug, what does it do, guys? So local anesthesia drug basically blocks the nerve or the nerve fiber. Okay. So for example, someone has sustained an injury in the hand or the leg. So what happens? That injury releases those mediators, right? So this is being carried by the nerves. From the nerves, it goes into the spinal cord, and from the spinal cord, it reaches the brain. And you have heard of the pain pathway. There is transduction, transmission, perception, and modulation of pain. That's the pain pathway, right? So how is the transmission of the pain taking place? So basically, action potential is generated by the nerve, and the action potential goes forward. Action potential goes forward. Action potential goes forward. Action potential goes forward, reaches the brain. So basically, how is that action potential going forward? If someone has sustained an injury, it's going like this: saltatory conduction. Where is it jumping? Of course, it's going from the nerves. So therefore, local anesthesia action takes place where? Local anesthesia acts at the nerves. What does it do? Once you give local anesthesia, it blocks the action potential from going forward. So these are both exam questions. Huh? Local anesthesia acts at the nerve. That is an exam question. Local anesthesia blocks that action potential from going forward. These are again exam questions. But point is, how does it block the nerve? Right? So normally what happens, this conduction is taking place at, where does the conduction take place, guys? Saltatory conduction. What are these points called? These points where it is jumping. What are these called? They are called nodes of Ranvier. In my class, there was someone sitting. I asked, as usual, as I asking with you, no? But the way I'm discussing with you guys, same ways. What is it? Sir, it works at nodes of Ranvier. Bhai, nodes of Ranvier is something else. Okay? And nodes of Ranvier is something else. Nodes of Ranvier means something else. Okay? Don't say, sir, nodes of Ranvier. All the people with the name Ranveer will be gone. Nodes of Ranveer. Okay, it's nodes of Ranveer. And basically, these are those sodium channels. Okay, so ultimately, what is happening? Your local anesthesia is working at these sodium channels, and it is preventing that sodium from going inside the channel. Okay, and therefore, because it blocks the sodium channel, that action potential which had come does not propagate further. This is exactly how it works. Okay, the action potential does not propagate further. It prevents that sodium from going inside. Remember one more point. It's not just that it works at the sodium channel. If someone asks you a question, remember local anesthesia can work at the potassium also, calcium also, and chloride also. It can work at all the channels, but the maximum effect takes place at sodium channel. See, it can block any channel which is capable of generating action potential. Na? That's the whole point about it. Okay. But more commonly, the maximum effect that takes place is at sodium channel, though it can work at all the channels which can, generate action potential. So this was about the local anesthesia drug, right? Now, you already know this answer. So we'll just take one or two questions more which are there, and then we'll call it off. I think I've discussed almost 5 papers with you, like last 1, 2, 3, 4, 5 papers with you totally, in total. Okay. So which of these agents is preferred for daycare surgery, guys? Daycare surgery. Correct. Correct. As we discussed before, when you're speaking IV drugs, it is propofol, right? I'm not saying ketamine cannot be used. Ketamine also can be used, but propofol is preferred. Okay. Thiopentone is routinely not used for daycare. Etomidate is not used, but ketamine can be used. If you remember, I told you ketamine is used for short procedures, out of OT anesthesia. So therefore, it's not that ketamine cannot be used, guys. It is used in kids. So it can be used for daycare. I'm not saying that, but propofol is preferred, or in fact the best agent for daycare surgery. Reason. rapid action, rapid metabolism. Okay, rapid onset of action and rapid recovery. So therefore, the patient can go home early. Okay, compared to any other drug. Early, rapid onset, rapid recovery, and it's got a very pleasant recovery when you come out of propofol. Okay, so that's why it is preferred. Other drugs which are used for daycare. So therefore, drugs, fentanyl or any derivative of fentanyl, maybe alfentanyl, sufentanil, or remifentanil can be used. Apart from that, I told you propofol can be used. When it comes to muscle relaxants, it is mivacurium or succinylcholine which is used, or benzodiazepines, midazolam is used. So these are the drugs which are used for daycare surgery. As you can see, these are all IV drugs. Hence, many times there's a concept of daycare anesthesia which is called as TIVA, total intravenous anesthesia, where you can see only IV drugs are being given. This is what is called TIVA. You have given fentanyl, you've given propofol, you've given mivacurium, succinylcholine, and midazolam. So these are all IV drugs. This is what is called as the concept of most painful or less painful. Right, let's do that also. One more question, as Dr. Med Psycho says, very important question. Which are the more painful injections? Okay, so painful injections, as we'll discuss. So remember, the most painful is propofol, which is almost the same and slightly more as etomidate, which is more painful than methotrexate, which is more painful than thiopentone. Right? These are all the drugs which normally work at GABA receptors. There's one drug opposite to them which does not work at GABA receptors. That is ketamine. It works at NMDA receptor. And in fact, ketamine becomes the other way around. It's a very good analgesic drug. Okay, thumbs up. This point also done, guys. So here we discuss the painful injections. So painful injections are propofol. So these are the most painful injections. And that is why, to decrease the pain of propofol, you have to always add IV lignocaine. The one without preservative. Lignocaine IV is always used. Okay, always propofol is added. Lignocaine IV is added to propofol before we give it IV. So etomidate is also painful, methotrexate is also painful, as well as thiopentone. All right, and ketamine is analgesic drug. It is not painful, not at all. Okay, ketamine is a very good drug going forward. Okay. Any questions and doubts, ask me, guys. Next, this was a FMGE question again, as I said previous year, important one. What type of anesthesia is required for dental surgery? Is it field block, nerve block, infiltration, all of the above? Next question. Yes. Answer to this one, guys. Confusion? नहीं. Dr. Khan is given one answer. Dr. Med Psycho is given answer. अरे बाकी लोग, there are so many other people also watching. मेरे को तो दिख रहा है यहाँ पे. डॉक्टर विकास, करेक्ट डॉक्टर विकास. सर इतना देर शांत बैठे थे डॉक्टर विकास, आप अभी मार्क किया आपने. नाइस. All of the above is the correct answer. For that, you need to know what are the types which are used in dental surgery. Right? Infiltration, nerve block and field block में क्या फर्क है? So let me go back to what I was discussing. Here, let me take the same example. यहाँ पे someone has sustained an injury. ठीक है? And there are the nerves which are over here. If I give the drug here itself, where patient is feeling the pain and it blocks the action potential from the nerve, this is called local infiltration. Right? But nerves are 2-3 branches of nerves are also there. So if I give it slightly over here, instead of giving it here at the site of injury, if I give the drug slightly above here, slightly, can you see this drug is going to cover 3 or 4 set of nerves? That is what is called as a field block. And these 3-4 set of nerves will further go forward and they will meet at a nerve plexus. This, if you give, it becomes a nerve block. Okay, so that is the difference between them. Local infiltration is a very small area which gets covered when you're kind of taking a suture. Field block is slightly bigger area compared to a local infiltration. Nerve block is almost the whole area gone. Let me show it with the terms of a diagram. Now can you see? Local infiltration means a very small area getting covered. Field block means slightly bigger area getting covered. Right, slightly bigger area. I told you 2 types of nerves getting blocked, so it gets blocked from here. This area gets blocked. This is called a field block. Infiltration was a very small area. Only this area getting covered. This was infiltration. One tooth. If there are two or teeth, three teeth, slightly bigger area, field block. And nerve block means the whole thing is gone right from here to here. This is what is called as a nerve block. Thumbs up, everyone. So the correct answer is, as Dr. Vikas has mentioned, this is field block, nerve block, infiltration, all is used. And remember, field block is a type of infiltration only. Okay, field block is a type of infiltration only. Thumbs up, everyone. Point clear? Okay, so this was a good question. I think your concept here has become slightly opened, widened. Now, important questions. ये जब तक नहीं discuss करेंगे, how can we end the session, right? How can we end the session without discussing this question, which has again been asked every second year now, second or third paper, every second or third paper they're asking you this. Patient has a gunshot injury with hypotension. Rapid infusion of saline is required. Which IV cannula would be the most preferred one? Okay, so you need to know the gauge, you need to know the color. Initially, we used to say don't remember the flow rates, but nowadays they are asking you the flow rates also. Okay. Yes. So I'm waiting for your answers. Yes, I got one answer I got from Dr. Med Psycho. Yes. बाकी लोग. Dr. Tech with Alex says D. Correct. Dr. Med Psycho also says D. Correct. No orange in option. It's okay. It's okay. From the options that we have, it is gray. It is gray in color. No, not yellow. So we'll discuss what are the colors and how they are. Okay. So remember, guys, the most common that you see, the center of all, is the pink colored one. Okay. The pink colored one basically is a 20 gauge. Okay. The one which comes pink is a 20 gauge, right? After that, if it becomes 22 gauge, so that is a blue color one. But blue is thinner, huh? Blue is more thin. So this pink one, guys, is the most common, which is used for adults. If the patient is in the ward, for giving injections, for surgery, right? If for adults, more commonly what you're going to use is a 20 gauge, right? Blue colored is 22 gauge. If someone is obese, adult, and you can't use it, so yes, it can be used for adult also, and it can be used for pediatric also. Blue. Then you come to yellow. This is a 24 gauge. It is more thin. So 22 and 24 are thinner. So yellow is used in pediatric patients, and then in fact even used in neonates. And there is a purple colored one, which is 26. This is used in neonates and preterm neonates. So remember, the blue, yellow, and purple, these are thin. They are not thick gauge. On the other hand, if you go on this side, you will get a green colored one. Then there is gray color, and then there is orange in color. Of course, there is one white color also in between, right? But white is not available in India. So here the green is what is called as 18 gauge, gray is 16, orange is 14, right? So all these three guys, remember, these are thick. These are thick in gauge. So where are they commonly used? All of them basically are used for fluid resuscitation, or they're used for blood. They are used in emergency, they are used in surgery, they are used in ICU. If you have to give blood to someone, correct. So blood transfusion, giving fast fluids, you will use green, orange, and gray. Okay. As I said, how to remember them. So pink is the most common one. So as I said, even I don't know, this was shared on all the groups, and this is how even I learned it. Even I didn't know how it was. So someone said, how you remember? Dr. Khan says gray and orange for surgical procedures. No, Dr. Khan. Even gray and orange are also needed only if you want to give lot of fluids fast. Otherwise, for surgery also we prefer to use a pink or a green one. We don't use 14 and 16 so often. It is only used if you want to give fluid transfusion or immediately blood देना है किसी को, blood transfusion. Okay? And white colored is that 17. So as I said, how you remember it na? So there is a purple galaxy, okay, yellow sun, blue sky, a pink flower with green leaves, with a gray soil and orange lava. This was one thing. I think this was one of the best ways to remember. This was also shared by someone, not by me. So I don't take any credit for that. But that is how people have remembered, and that's a nice way. Okay, that's a nice way to remember. Now, when you speak of the flow rates, guys, remember 20. This flow rate is around 50 to 60. The 18, remember 18 is around 80. The 16, you can remember it is around 160 to 180. The 14 becomes even bigger than that. So 14 they might not ask you. You need to remember 18 and 16. You can remember 18 as 80. So 18. The 16 you can remember it as 160 sort of thing, right? And when you speak of the pink one, it is 54. The blue one is 33 and the yellow one is 20. So these are the flow rates. Out of them, remember the three important ones that you should be knowing are these three. I don't expect you that they'll be asking you the flow rates for yellow and purple. This 80, this 50, and this 33 is what you should know. This is not what you should forget. Okay, so this is about the IV cannula, very important point. Okay, all right. So last question we will take. A patient underwent surgery and during recovery he was shouting and having hallucinations. Which anesthetic agent was used? Any questions about the previous one? Ask me. Otherwise, this is the last question that we'll do, and remind me to save it. So this covers up to 5 papers. All 5 papers we have covered. Okay, previous year's questions. And we discussed the concepts also. No, that's not the answer. Subse best drug from anesthesia. It's used in party circuits. You people don't know. It's a party circuit drug. You go to rave parties. It's called Special K. Special K. What is K for? Special K. Ketamine. Ketamine. Remember, ketamine is a drug which is phencycline derivative. Okay. So phencycline is a psychiatric medication. So this drug has peculiar properties compared to others. All the other drugs did not have this. If you remember, all the IV drugs worked at GABA. No, it's not sevoflurane also. It is ketamine. Shouting and having hallucinations. Okay. Remember, there's a point for ketamine that you should not forget. Apart from analgesia, this drug produces dissociative anesthesia. This is an important point. Right. So it stimulates one part of the brain, it depresses other part of the brain. So because of that, what happens is, of course, it is producing anesthesia, analgesia, sedation, okay, amnesia. All these are properties. It is producing dissociative anesthesia. It is producing analgesia, right? It produces wonderful sedation. It produces amnesia. ये सब इसके अच्छे properties हैं, for which I use it in anesthesia, and people use it in parties, right? That's why it's a party drug. That's not why it's not a party drug. It's a party drug because apart from these anesthetic properties, it produces wonderful hallucinations. Oh, wait, I'm keeping it. I'm coming back again. Thankfully, I saved it. Okay, so it produces wonderful hallucinations, right? Apart from that, it produces this delirium and dreaming. And these are the properties that are seen with ketamine and they're peculiar to ketamine. So it produces something called as dissociative anesthesia, right? One part of the brain gets stimulated, one part of the brain gets depressed. It also produces hallucinations, delirium and dreaming, emergence delirium. And that is exactly why the patient was shouting and having hallucinations, okay? So that is one important point. Another point regarding ketamine is, remember, all the other drugs, Med Psycho says most addictive or less addictive. Yes, it has addictive potential, but guys, remember from anesthesia, these two, both of them have addictive potential. But more than ketamine, it is propofol. More than ketamine, it is propofol, because I told you, propofol produces a rapid onset and rapid recovery, right? Apart from that rapid onset and rapid recovery, there's another important point to propofol which I mentioned and I not written, that the recovery produced by propofol is very, very pleasant. It produces a very, very pleasant recovery. So when you wake up from propofol, one feels that you have woken up from a deep sleep, and a wonderful sleep which someone has never had. And that is why, because of this property, propofol is more addictive than other drugs which people don't realize. Okay, ketamine, no doubt, it produces hallucinations, but more than hallucinations, people want, that feeling of getting up after a good sleep. And that is what is seen with propofol. So propofol is a highly addictive drug. No doubt ketamine is not. I'm not denying it. You can't compare the properties per se, but ketamine is more the one that produces hallucinations, delirium, and dreaming, which may be good or bad. But propofol has a very, very pleasant recovery, because of which you get that addiction potential. Okay, guys. All right. So one more point, as I wanted to point out, that ketamine, remember, maintains the respiration. That's the difference between propofol and ketamine. That ketamine respiration is sort of maintained, and it's a very good bronchodilator. Remember, it was a drug of choice in respiratory patient, and it's a very good bronchodilator. I did not mention it there because I had to discuss this point here. So the respiration is maintained with ketamine, and it's a very good bronchodilator. That is why it was a drug of choice in respiratory patient with bronchospasm. If you remember, we've written that down. So respiration is maintained, and it's a very good bronchodilator. Okay. Propofol, yes, it can be used in respiratory patients with no bronchospasm, but it's not a bronchodilator per se. Okay, but ketamine is a very good bronchodilator used in pediatric patients also. All right, guys. So any questions and doubts, ask me. Otherwise, we finished off all the questions. We discussed all of the papers which were there. Okay. Any questions or doubts? So we'll do one thing. Last, we'll try to finish off with one song. Okay. I had it here only. Before starting the class, I was playing, so might as well. Yes, guys, any questions or doubts, ask me. Anyone? पहले questions हो जाए तो फिर बंद करें. Any questions or doubts? No questions. Okay, guys, thank you, Dr. Med Psycho. Thank you, everyone. So 2 days, you people joined me. We had sessions where we discussed all our previous year's questions. Thank you for sparing time and joining on this session. Okay, thank you, everyone, and hopefully it is helpful and beneficial to all of you. And okay, My Telegram ID is Dr. Vinish. If there are any questions, you can ask me there. Okay, I'll just share my Telegram ID with you. So any questions and doubts, you can go ahead because someone had asked me. Dr. Khan says you're all-rounder. Thank you, Dr. Khan. Inspired by Hardik Pandya, right? So that's my Telegram ID, guys, Dr. Vinish. There also you'll find me playing a guitar only with the photo. That's my Telegram ID. You can just get in contact with me. Plus the PDF of this session is available. All right. It's my Telegram ID. Dr. Vinish, DRVINISH. Okay. Dr. Med Psycho says entertainer. हाँ यार पढ़ाई के साथ साथ ना always de-stress yourself. I always say that. Okay, we have to clear the exams. You have to get the marks, and you're doing it for your parents. I totally agree. Of course, for you also. But for all the FMGs, remember, more than you, na, it's your parents who get absolutely happy. Dr. Sumit Kale says hello. Hello, Dr. Sumit. So FMG students, Dr. Khan says, thank you so much for clearing the doubts. Thank you, Dr. Khan. Thank you so much. Okay, thank you guys. Thank you. So I was saying FMG students, definitely when you clear, you will feel proud. But more than you, it's your parents who feel proud. Okay, so you have to do it for them. Keep that in your mind. Right? The last time the result was very good. It was almost 40% FMGE. So please give your best shot, and you have to have your concepts, and you have to work hard. There is no shortcut to success. Okay? Use concepts, use mnemonics, use whatever you like, and de-stress yourself. So for me, it was like playing the guitar. For you, it can be whatever you like, but always de-stress yourself. And remember, you have to clear the FMGE for your parents. That's the most important point. Parents, don't forget it. Okay? NEET PG, तो सब लोग बोलते हैं हाँ ठीक है, I'll clear. But you know, the people who are giving FMGE, I have seen the happiness on the faces of parents. You know, the students have cleared. Yes, they are happy. I've become a doctor. मेरा ये हो गया. India में I'm done. India में I'm registered. But it's the parents who feel absolutely proud about you. For all the FMGE students, do it for your parents. Right? Thank you, everyone, and all the best. Do well. That's my Telegram ID. When you clear, let me know. You people can share. I want all you with your marks, telling me I've cleared with these marks. Okay. Bye, guys. Bye bye. Dr. Sumit Kale says, third year abroad, so should I focus on FMG or next? Dr. Sumit Kale, okay, good question. Dr. Sumit, let me tell you, the concepts don't change. Whether it is FMGE or NEET PG or FMGE or INICET, you will see my session today only. I don't know when you joined the session, but if you will see the session today, there were two places where I said this is a INICET question, but that has been asked for FMGE. So what's the meaning of that? The point is the concepts remain the same. The concepts don't change whether you're giving INICET or you're giving FMGE or if you give next. The concepts are not going to change. If there is ARDS, the concept is not changing. If it is pulmonary edema, the concept is not changing. If we are discussing endotracheal tube, the concept is not changing. If you're discussing halothane, sevoflurane, desflurane, the concept is not changing, guys. And that's what we always say, the concepts have to remain the same. They will never change. So if you're taking care of the concepts, whatever exam is there, you will clear. And we have told FMG students so many times, I've been teaching for 12 years now, 12 years almost, right? So I have seen FMG students, when they clear FMGE, they are the best students who can clear NEET PG. Problem क्या होता है पता है? As soon as FMG people have cleared FMGE, then they become lax. Oh, छोड़ दो मैं पास हो गया. But the ones who have put in little bit more effort after FMG, they have become so easy for them to clear NEET PG because they have already given one exam like that. You will see so many students and you will see so many YouTube videos of students who have cleared FMGE and are now working in the premier institutes of the country. The same INICET, they've all cracked INICET also. You can see the YouTube videos, and I'm not joking for that. It just means once you have cracked your FMGE, your concepts are clear, a little bit more effort, and you'll clear your next exam also. Dr. Sumit, that is for you, right? Thank you guys for joining me at this session. Any other questions or doubts? This is my Telegram ID, Dr. Vinish. Okay? So all the best, everyone. Bye-bye. Take care. If there are any more questions, I'll take them. But I think all done. Okay, chalo, bye-bye, guys. Bye. I'm saving this also. Huh? Let me save it. Thank you, Dr. Sumit. Thank you. Thank you, everyone. I'm keeping this and I need to save it. The PDF will be available on the group. You will get the PDF also within an hour or two. You'll get this PDF. Saved it. Okay. Bye-bye, guys.